Hello everyone. Today our subject of discussion will be dizziness. Dizziness is such a broad symptom which is not specific. It bothers quite a lot of people. So does it bother the doctors? I don't think there are many doctors who are excited when patients walk into their rooms and complain of dizziness. It can be a difficult task for doctors to resolve, and it's also quite a disturbing symptom to patients. No two patients who come in on a single day complaining of dizziness would likely have the same type of dizziness or likely have the same cause for their dizziness. So that's what we'll be focusing on today. And like I said, it's a complex topic. So therefore, I'll probably just be focusing on a small subtype of dizziness and help to explain it, how we look at it, how we diagnose it, and what you need to know about it. Before going into that, once again, I am Dr. John Oluwole, your favorite neurologist, and this is BrainGist channel, a channel dedicated to enlightening people about the brain and its disorders, about everything that affects the nervous system, not just the brain, right? So welcome to the channel. Please subscribe, share, leave your comments behind, like, and let's grow the channel together. Yeah, so I'm focusing on dizziness today, and a particular subtype of dizziness is what I will be elaborating on today. Before going into the subtype of dizziness I want to elaborate on, I'll first say, like I mentioned at the introduction, that dizziness is not a homogeneous symptom. It's quite heterogeneous. So some people will come in and describe a spinning sensation. Some people will describe a feeling of disequilibrium. Some people will describe a feeling of faintness. Some people will describe a feeling of imbalance or like the environment swaying. Some people describe when they turn their heads to one side very rapidly, they feel unsteady. So there are so many potentially different ways that people describe their dizziness. And some people also, when they cannot focus visually, they also call it dizziness. So I think the first thing I'd like you to take away from today's video is, if you have dizziness, try to close your eyes for a moment and think about the best way to describe your dizziness so that your doctor can get a sense of what exactly you're feeling. And that's something I try to do. Sometimes I boil it down to saying, okay, I don't want you to use the word dizziness. I just want you to imagine you were describing your symptom to your 10-year-old child, wanting them to understand exactly what you're feeling. So I want you to put it into that word. And some people now describe in various ways. So it can be really complex. So, but then there's this sense sometimes, a subtype of dizziness that, in which people feel a sensation of spinning, either that they are spinning or the environment is spinning or tilting, and that is what we call vertigo. So vertigo is a subtype of dizziness. There are all other types, several other types of dizziness like I mentioned. So we try to focus on that. I think that's usually the first step in the clinic. And then the second thing is, I realize not everyone is able to describe their dizziness, so I don't find it too helpful. But of course, if someone can give me a clear-cut description of vertigo, then that helps me, to know what they're experiencing, and or as opposed to someone who's feeling faint or feeling unsteady and stuff. So, but I don't put much emphasis on that as a neurologist who sees a lot of patients with dizziness and trying to resolve the cause of their dizziness. And one funny thing I find, which is quite common with patients of different backgrounds, is And even doctors. You so patients come in and they tell you, doctor, I've got dizziness, and I saw a doctor and they told me I have vertigo. Or sometimes they say, I went to the emergency room and the doctor told me I have vertigo. I find that really very funny because vertigo is not a diagnosis. Vertigo is just a type of dizziness. So we've got to find the cause of the vertigo. So vertigo is just a description of a type of dizziness where you have a sensation of spinning, either yourself spinning or the environment is spinning or tilting in whatever way. So that cannot be your diagnosis. So that's your symptom. So that's, by the way. So what I'm focusing on today is the second aspect of things. So after describing what type of dizziness you're feeling, the other thing we usually want you to focus on and be able to tell us succinctly when you come to the clinic is whether you are continuously dizzy or it's intermittent. And there are those in whom the dizziness is intermittent and triggered by certain situations, and that's what I'm focusing on today. So there are those patients that are completely well in between episodes and they have distinct episodes of vertigo. Now we all know what vertigo is, and these are triggered by certain head movements, like sometimes when they're trying to lie down on their bed, they feel, intense spinning vertigo or instability, and that lasts for not more than a minute and then slowly resolves, and then in between they're completely fine or just slightly dizzy in between. So that is what we call positional vertigo. So these individuals are fine in between, and then it's only when they go in certain directions or certain direction of head movements that they have positional vertigo, and that's positional vertigo. And then there is an entity we call BPPV. That's benign paroxysmal positional vertigo. And that's my main aim today to talk about. And I think it's one of the commonest causes of vertigo. In fact, in my practice, I think after migraine, I think BPPV is probably the next commonest cause of vertigo. And so we call it benign paroxysmal positional vertigo. And this is a very benign entity. Benign means that it's not a dangerous entity. There's no injury to the brain in this entity. It's benign. It's paroxysmal in that it comes in episodes. And, in between episodes, patients are completely fine. It's positional because it only happens when people tilt their heads in certain directions. For example, they're trying to pick something from the top of the shelf and the head tilts backward and they feel it, or they're trying to turn in bed, or they're trying to lie down flat and then they feel. And some people do not feel it when they lie down. It's actually when they're coming back up that they feel some spinning. All of these would be the type of complaint people who have BPPV would have. And what actually happens in BPPV is that we believe that the inner ear, the ears we all know are the organs of balance, and it's got the outer ear, which we can see, and then we've got the middle ear and then the inner ear. So the inner ear actually is where BPPV happens, and the inner ear has got a labyrinth, which is a complex structure. And in this labyrinth, we've got parts of it that are shaped like tubes, 3 of them. These tubes are fluid filled, and they are not supposed to have any particles in them. And then we now have another part of the inner ear that is like a sac. So this part actually has some fluid as well, and at the same time it has these small tiny crystals. Now these crystals that are embedded in the sac give the brain a sense of motion forward or motion upwards, but not angular motion. When you do angular motion, that is something that is controlled by those tube-like structures of the inner ear. So when you have the crystals within the part, the sac-like part of the inner ear, what we call the utricle and saccule, when you have these crystals getting dislodged and moving into the ones that are tube-like, when you have that dislodgement happening, then that is when BPPV happens. So again, to further clarify, the inner ear has got like two parts. We have the part that's called the saccule, and that's like a sac-like structure. It's got some crystals embedded in it. And then we have the other side, the other part that contains tube-like structures, which shouldn't have any particles or any crystals. So when you now have these crystals breaking off from the saccule and getting dislodged into the tube-like structures, which we call semicircular canal, that's when BPPV happens. So when you now tilt your head in the direction of any of those tube-like structures, the semicircular canals, then because these crystals are in there, so wrongly, they trigger emotion and cause the brain to misunderstand the signal. So they basically cause misfiring of signals, and that's what causes, that spinning. And usually when we test it in the clinic, we can see the eyes actually rotating, and that's what gives that vertigo sensation. The eyes actually begin to spin. So we do that test in the clinic, what we call the Dix-Hallpike maneuver, and that's where we test for this dislodgement of crystals. And if it's positive, we do a very simple treatment, which is to perform some maneuvers in the clinic to help to, there's a way we bend the head and twist the body sequentially, and that way, under the effect of gravity, we can slowly dislodge these crystals out of where it is wrongly positioned and push it back into the utricle and saccule where it's supposed to be. So this is just like this is meant to be an introductory video, so to speak, to the concept of BPPV, that this is how it presents, and this is the course, and this is what we do for treating it. I do hope you learned something and understood it. And perhaps the part I did not add is, why would this happen? Why would these crystals actually get dislodged in some individuals? Sometimes we don't have any cause. There's no reason. We don't find any reason. We just realize these crystals are dislodged, and we successfully treat them in the clinic. And then sometimes it follows a viral infection like flu. We just see it developing afterwards. And then the other one that happens is after head trauma. So perhaps people bang their head against something hard, and that probably caused some shaking and dislodgement of those crystals. Then the latest one I saw in the clinic just 2 days ago, or yesterday even, no, 2 days ago, was caused by head trauma. This individual actually, unfortunately, got run over by a vehicle, and then she fell and hit her head against the curb, and then came in with concussion. And after the concussion symptoms resolved, she continued to be troubled by BPPV, and we identified that by the Dix-Hallpike maneuver, and we were able to reposition the crystals. So that's the lesson for today. I do hope you learned something. Please, if you do, like, share, comment, and don't forget to subscribe. I hope to see you again in future videos. Thanks for watching this time. Take care and bye.